Dr. Sita Chokhavatia is a gastroenterologist with an office in Paramus. She completed her medical education from Seth GS Medical College in India and completed her residency in internal medicine and fellowship in gastroenterology from Jersey City Medical Center. Dr. Chokhavatia is board certified in internal medicine, gastroenterology, and geriatric medicine. Welcome, Dr. Chokhavatia.
Thank you, Liz, for that nice introduction. And thanks to everybody that's joining us today, taking time out from the new year, because it is actually the first day of the year if you lived in, 5th century BC, so before the Gregorian calendar. And if you had waffles today for breakfast, you were celebrating International Waffle Day. But today we're going to talk about colon cancer and the Colon Cancer Awareness Month, because March is Colon Cancer Awareness Month. If anything, and if there are women in this audience, it is also the Women's History Month. So we have a lot to celebrate in March, and we have one more week if we need to celebrate our month of colon cancer awareness and Women's History Month. Getting to why this is a colon cancer awareness month. In 2000, February, March was declared as a colon cancer awareness month because it is the third most commonly diagnosed cancer and the second leading cause of cancer deaths. The median age is usually 68 years, with an average lifetime risk in the US of 1 in 24. So if you know about 100 people, you probably have come across somebody with a diagnosis of colon cancer. About a fifth of the colon cancer happens to occur in familial aggregates, and familial syndromes increase the risk for colon cancer. Lynch syndrome is one of those familial syndromes with a risk of 2 to 4% of all colorectal cancers. And familial adenomatous polyposis, or FAP, is a gene that is passed on, inherited autosomal dominant, in 0.1 to 1% of the colon cancer patients. There are treatment options, but they're limited when it is diagnosed at an advanced stage. And the incidence and the mortality rates have declined in the US since the 1980s because of collaborative multi-specialty preventive measures. Colonoscopy and polypectomy prevent cancer. So unlike mammography for breast cancers or PSAs for prostate cancer, when colonoscopy finds a polyp and your colonoscopist or your gastroenterologist, colorectal surgeon removes that polyp, you've actually prevented cancer because you've removed a precancerous lesion. It's not just the US, though. There are several countries with pretty high incident rates for colorectal cancer. And you can see that in China, because of its large population, they have a higher incidence rate and more patients with colon cancer. It is the third most cancer worldwide and approximately 10% of all cancer cases in the world. It is also the second leading cause of cancer deaths worldwide. I bring it closer to home in Bergen County. New Jersey is the hotspot for increased mortality seen in women with early onset colon cancer. This was a study done that was local and published in 2020. And we found that physical inactivity and fertility were community health behaviors that moderately correlated with women diagnosed with early onset colorectal cancer and their mortality. So again, something that we should be very aware of in Bergen County, especially in New Jersey, Bergen County. Now, colorectal cancer affects older individuals, as I said earlier, and the majority of cases occur in patients 50 and above. Most of the cases are sporadic, which means they occur without any kind of family history or any other pre-existing conditions. 90% occur at the older age, so between 65 to 74 years of age. But in 2020, the data showed that 11% of colon cancers and 15% of rectal cancers occurred in patients less than 50 years of age, which then led to the change in the average age for patients to undergo screening, and it is now 45. We'll talk about that in a minute. The recent trend of increased colorectal cancer in younger adults is a complex issue. It could be an interaction of lifestyle, diet, or obesity. There are several lifestyle factors that contribute to the development of colon cancer or colorectal cancer. high intake of processed meats, or low intake of fruits and vegetables, or a sedentary lifestyle, all lead to an increased risk, as do obesity, smoking, and excessive alcohol consumption. The incidence and impact of colorectal cancer can be significantly reduced by implementing primary prevention strategies such as adopting a healthy lifestyle, avoiding all of these modifiable risk factors we mentioned before, as well as early detection and even prevention through screening methods. There are several different tests for screening, and the American Cancer Society recommends tests that find polyps, so you're preventing cancer by removing that polyp, and find cancer, tests that mainly find cancer. And in the tests that find polyps so that we can prevent cancer are flexible sigmoidoscopy, which is a camera that goes up to the sigmoid colon, or the last part of the large intestine, versus a colonoscopy, which is the camera that goes all the way across to the beginning of the large intestine and the end of the small intestine. We used double contrast barium enemas, but that is no longer considered ideal, and we do not offer that as a screening test. And then CAT scans, which are virtual colonoscopies, are actually CAT scans done with contrast. The only problem is if they find a lesion, you still have to go through the repeat preparation for colonoscopy and get the colonoscopy to remove that lesion. The tests that mainly find cancer are stool tests, and amongst those stool tests, there's something known as a guaiac-based stool test, an immunochemical test, which is called a FIT, a stool DNA or RNA test, the one that you see the happy colon on the TV ads, telling you to get that, delivered by UPS, and then you give a specimen of your stool, it goes back to the lab and they check it out and send you the results. A Cologuard Plus is the next generation of the Cologuard, which was approved by the FDA in 2024, but will be available sometime this year, and ColoSense, which is an mRNA test in the stool. There are also liquid biopsies, which are blood-based tests, and these are not highly recommended, although the FDA did approve of them this past year. And the reason being that they're not as specific, nor are they very sensitive, and therefore you get a higher cost, but not a big bang for the buck. For all of these tests, if they're positive, a colonoscopy must be done to find out if there are polyps that are causing them to be positive. And then we look at them as first tier, second tier, and third tier. So the first tier is the best test, is usually a colonoscopy. If it's negative, you get it done every 10 years. A second tier test is the one where it's a two-step test, where you do the test of stool or the colonography, which is the CAT scan. And then if it turns positive, the second step is to get the colonoscopy done. And then the third tier is a colon capsule, which is a camera that you swallow. The problem with that is we do not have too much of a data, and since we don't have those data, we don't recommend that as a part of the screening modalities. The ideal non-invasive screening test should have a high sensitivity, which means you can diagnose an early stage curable cancer, an advanced or precancerous lesion, and then it decreases the mortality by decreasing the incidence and early recognition. It should also have a high specificity, and by that it means there should be low false positive. So if you get a positive result, it is because it's a true positive and not because there was nothing and it turned out to be a positive test. The test has to be affordable, accessible, and user-friendly, because if it is all of these, it increases the acceptance. And if it's convenient, there are more patients likely to adhere to the recommendations. With the newer tests, the stool test and the blood test, there is a menu of options. And as you can see, a lot of these were approved last year from May, July, and even October. The other two tests have been around for a while, but like I said, the blood test, the Septin9, is not something that we've usually recommended. And the Cologuard is one that seems to be more specific and sensitive than all the other stool tests and the blood tests. At the bottom of all of this, like the title for this talk, the best test is the test that gets done. So you depend on patient preference, the test performance, and the cost of the test. And at the end of it, it's a shared decision between the patient as well as the physician to see which test the patient will complete. Because there could be any number of tests. If they're recommended but not completed, it doesn't make any difference. There are multiple barriers to screening. One is lack of recommendation from the doctor or insufficient or no patient counseling. So the patient-specific barriers are not addressed, and there's confusion over the different guidelines or the different tests. And some of this might relate to the lack of time that the doctor has with the patient when they have other more pressing issues or symptoms. From the patient's perspective, there's a lack of knowledge or a low perceived risk. There are other health concerns, their fear of procedure or the outcome, embarrassment about getting this done because it is a colonoscopy, then you're going to have to get the prep. There may be low health literacy. There may be mistrust of healthcare systems because there's disparity in care, and we've come across that when there are language barriers, or if you're in a rural setting, there is access of care that is at fault. And then there are systems and societal problems where there's inadequate or no health insurance, no access to physicians or subspecialists, and no regular source of care or no primary care physician. Colonoscopy prep can be a barrier to colorectal cancer screening. The preps, there are many of those, and sometimes people were really aghast at the amount of fluid that they'd have to drink, the big volume that they would see, the big bottles that were being given to them. And now we know that there's a split dose. So there's 2 small bottles, although you must take a lot of liquid to make sure that you have a clean prep. Because if there's a poor prep with a lot of stool lining the colon, most of the mucosa is not seen and a lot of the lesions can be missed. There are several instructions that are given prior to the colonoscopy, and especially now with the obesity and the diabetes medicines of GLP-1, they have to be stopped. If the patient's on antiplatelets or anticoagulation medicines, those have to be stopped. If they're on diabetic medicines, you want to make sure that they don't get hypoglycemic or low sugar. So everything depends upon the patient who's going to take this test. At the end of it, you really want to get a clean prep so you can see these small lesions that are evident if the prep is done well. It's overall a safe procedure, but if it's a poor prep, you can miss lesions. If you take a polyp out, they may be bleeding, especially if the patient is on blood thinners or antiplatelet medications. Very low risk for perforation, infection. There may be aspiration, which is one of the risks with anesthesia, and sedation, and then electrolyte abnormalities usually occurring because of the preparation. There is an increased risk for colon cancer if a polyp is removed. So after a colonoscopy, we have guidelines on when we recommend a repeat colonoscopy to be done. And that can vary anywhere from 3 years to 10 years. But if there are no polyps that are found, the recommendation is to come back at 10 years. And then there is high-risk patients, and these are patients that have familial syndromes. And I'm not going to go through all of these, but there is a Lynch syndrome I talked about earlier. There's a familial adenomatous polyposis. There is another MAP, which is a MUTYH gene with polyposis syndromes. And then there's serrated polyposis syndromes, and patients with ulcerative colitis and Crohn's disease are also at increased risk for colon cancer, and they're the ones that will go through screening, maybe even every year or every other year. When you look for colon cancer or colorectal cancer risk assessment, there are non-modifiable risk factors, and one of the most important one is age, because as one ages, the risk for cancer does increase, and our recommendations now are to start screening at age 45, because there are some patients that are younger than 50, which was the usual age we used to recommend colon cancer screening for, that do get colon cancer at an earlier age. Male sex, African American race, Ashkenazi Jewish ethnicity, family history, prior history of radiation for either testicular cancer or prostate cancer, and inflammatory bowel disease. So these are non-modifiable. You can't change any of this. What you can change is your weight. You can have interventions to decrease from going from obesity to maybe overweight or normal weight, diabetes, having a good control over the blood sugar levels, increasing the diet of cruciferous vegetables, decreasing processed meats, cessation of smoking, and decreasing or moderation in alcohol intake. The protective factors are diet that are rich in cruciferous vegetables, garlic, magnesium, and fish. Certain medications also may act as protective factors, but we do not recommend any of these medicines purely for prevention. And these are observational data, so they do not influence screening recommendations. Average risk, 45, you must get screened. The American College of Gastroenterology put out clinical guidelines. And the most important takeaway over here is that the age was decreased from 50 to 45, because when we screened patients between the ages of 45 and 49, their incidence of advanced polyps was the same as when patients over 50 were being screened. So recommended age for average risk, that means there's no family history, there are no other circumstances that like IBD, inflammatory bowel disease, that puts one at higher risk. And so these are patients that need to be screened at 45. And also, we prefer organized screening, which means you want to have a whole population screened for colon cancer as opposed to opportunistic screening, where the patient shows up at a doctor's office and that's when they're afforded screening. And what I mean by organized screening is Valley actually has a fast track program. So if anybody's seen any of the ads where it's a cinch, and that was the ad that has been out there for 5 years, there's a number to call, and there is a physician's assistant, and she can take your history. If you have no other medical issues, you will be scheduled for your colonoscopy with a physician of your choice, either at Valley Hospital with a colorectal surgeon or a gastroenterologist. So that's fast track colon cancer screening. And it's a shout out to our fast track program PA. We suggest following, so these are suggestions, and we say, improve adherence with patient navigation, patient reminders, and then providing clinical decision tools to physicians. We suggest against the blood test, and that's what I mentioned earlier. The other part of this is, what do you do when you have a family history? If it's a first-degree relative, and first-degree relatives are parents, brothers and sisters or siblings, and children, because I've had a patient at age 70 whose daughter at age 40 had cancer, and she then presented for colon cancer screening at age 70. So first-degree relatives are children, siblings, and parents. However, if you have a second-degree relative, that would be grandparents, aunts, uncles, and cousins. Difference being first-degree relative, you might have more intense screening. Second-degree relative, you might do it less so. The other thing to remember is that all the endoscopists are held liable to having quality colonoscopies. So there are certain things that we look at amongst all the endoscopists, and they're meeting the quality measures. So that's all about the screening and how we go around it. How about colorectal cancer? How does it present? It can present with a change in the bowel habits. So if you see there's a change in the form from normal sausage shape to maybe pencil thin stool, or rectal bleeding, weight loss, fatigue, anemia, pain or indigestion sometimes. And when you go to the doctor and they check you and it's a positive fecal occult blood test, it may be a kind of indication that you should get FIT testing or other tests, because sometimes the positive test with the rectal exam could be from trauma. Especially the younger patients, because we know there's early onset colorectal cancer, they should be tested if they present with any of the symptoms above. Unusual presentations usually mean that there's cancer that has spread, and this could be infection in the belly or obstruction or even fluid in the belly or ascites. So to recap, what we've talked about is updated guidelines for colorectal cancer screening. Very important, average risk, 45 years. And if you get a colonoscopy and there's a polyp that's removed, you've actually prevented cancer. We kind of fell backwards during the pandemic. And so we find that we're catching up with more of the colon screening in the last 2 or 3 years. 2020 and 2021, it was almost at a halt, the screening. In 2024, we had a lot of approved stool tests as well as blood tests or liquid biopsies for colon cancer screening. We've updated the guidelines for surveillance so that we're not doing everybody as soon as 2 or 3 years, but we're giving them 5 to 10 years, depending upon the polyp that's found. We know that there's increased risk factors, which includes a personal history of polyps, inflammatory bowel disease, a family history of cancer, such as the Lynch syndrome. We know that the colorectal cancer symptoms are subtle, and the diagnosis may often be at advanced stage. So therefore, colonoscopy screening is very essential, and colonoscopy and polypectomy prevent colorectal cancer. We know that in up to 90% of the cancers can be successfully treated if they're, caught early. Most of the patients have improved life and quality of health-related quality of life. So don't be a fool and test your stool. We know it reduces colon cancer mortality by 40 to 50, 60%. So get to an older age by getting these done. And finally, you have inner beauty and you have a video from your colonoscopy to prove it. So you were a grown-up and you got your colonoscopy. And with that, I thank you for your attention. If there's any questions, I'm happy to take them. And I think Liz would have them. Liz, do you have any questions?
Yes. Well, the first question that came in, I'll just let people know if you do have questions, you can put them in the Q&A portal located at the bottom of your Zoom screen. One person is asking if you would share your slides. Is that something that
I
if you,
usually don't because some of these are, taken from other places where I haven't asked for permission.
okay. And are there any, someone else, am I completely asleep during a colonoscopy?
Absolutely. We do this with anesthesia, and your blood pressure, your pulse, your oxygen, everything, your EKG, everything is monitored. So it's very safe. And we actually do them in the old Ridgewood Hospital at Valley. If you have other issues and you're at high risk, then we may do them in the new Paramus Hospital. But by and large, these are very, very safe procedures.
Okay, I see someone has raised their hand. Unfortunately, we don't have a way to let you ask your question unless you enter it through the Q&A portal. So let's see if,
The person
also,
that wanted to share the slides, I mean, if they have a specific question or a specific slide, maybe I can clarify it for them, because I have a lot of slides that I usually give lectures to medical residents or at medical conferences. So some of those were like an overkill, I think, but I just wanted to have all the information out there for everyone.
so we did have another question come in. What is the estimate time for a colonoscopy procedure?
Excellent question. So usually it takes no more than 10 minutes. And the reason it's 10 minutes is it takes some time to reach from the anus, from the bottom end to the beginning of the colon. The colon is usually about 3 to 5 feet in length. So, we do traverse quite a distance. The reason that it takes the extra time after we've reached the cecum or the end of the large intestine is we are graded upon how much time we take to come out. So as we are backing out, we're taking a good look at the colon mucosa. And when we look at it, we're looking to see if there's any subtle changes. Like I said, if it's not a clean prep, we try and wash with water jet. That's with our endoscope or colonoscope. So it takes a while to come back. And the minimum time used to be 6, which might be increased to 8. So again, that might increase from 10 to 15 minutes for the whole procedure. You do need to come in an hour earlier because you get checked in, they get you to change your clothes, they get you to start the IV. The anesthesiologist talks to you, and if there's any concerns, those are addressed. And after the test is done, it takes about 15 to 20 minutes to wake up. Usually patients get up right after the test is done, and within 15 to 20 minutes, they're getting their snacks. So all told, you're taking about 2 to 3 hours out of your day. You do not want to be working that day because you're in a very good mood. And as I tell people, if you have kids and the kids say, can you buy me a car? And you'll say, sure, which kind do you want? Do you want a Lexus, a Mercedes? So you probably don't want to do anything, sign anything that day or work that day.
Is there greater complication from colonoscopy with older adults?
There is definitely a greater chance for complications, and the risk kind of tends to be higher if there are comorbidities. So if there are pulmonary or cardiac issues, age by itself sometimes causes a change in the way you feel thirst. So the preparation can be a bit difficult. Some of the older patients have constipation, so sometimes they need to take extra doses of the cleanse. So that might be a problem. Sometimes they may not be able to cleanse completely. Other than that, we usually take precautions with our older patients. So it's taken into account, and the risk for bleeding or perforation is absolutely dependent upon if there's a big polyp or if the patient's on multiple medications for, um, you know, um, anticoagulation or, blood thinners. So those are the things that might increase the risk, but everything is taken into account before the procedure is scheduled and through the procedure and post-procedure.
Okay, is colonoscopy safe for someone who has had a sigmoidoscopy due to a perforation from a previous colonoscopy?
Great question. So one of the complication is perforation. Sometimes it happens if there is a lot of looping in the colon, or the colon is very redundant, which means it's just longer than the 3 to 5 meters. And sometimes it may be because there's diverticulosis. So that wall is thinner, and sometimes it can be a perforation. But once that is healed and if the surgery's been done, there should not be any risk, because usually we are very careful and we try not to put too much air in and try to take it very easy. So there is not any increased risk if it's done in a very, proper manner.
Okay, are there any concerns that by expanding the biomarker panel in Cologuard Plus that will pick up more clinically insignificant lesions and end up overdiagnosing?
Again, excellent question. With all genetic tests as well as the stool tests, there is always the chance that you might pick up something that is, false positive. And patients prefer to get the Cologuard test. It's easy, it's convenient, it comes to your house, you can send it back. The problem is it can be positive and we picked up polyps, but a lot of times we find nothing. And it could have been a positive test, not because of the genetics, but because patients might have hemorrhoids and there might be some blood that came down there. The other side of it is if there's any lesion higher up, there might be, gastritis or some other reason. Even sometimes if you have bleeding gums and you swallow that blood, it may show up positive in that Cologuard test, because the Cologuard test has two parts to it. So it may pick up nothing, or it may pick up, so those are the false negatives, but it may also pick up things that really were an overdiagnosis and a false positive. So excellent question.
Okay, is the stool test usually covered by insurance or is that out of pocket?
Most of the stool test and most of the screening is covered by insurance. The colonoscopy that gets done after a positive test is something that we are advocating at the Capitol in DC, that it gets covered as well, because if you get a positive test and you don't do the part 2 of the screening, what use was it doing the first test? So again, these should be covered, and Medicare does cover for a positive stool or blood test and then getting the colonoscopy. The blood test by itself is very expensive, so that is not yet covered. And that's part of the reason, like I said, it's a very expensive test and it's not got the greatest performance. So not something that we recommend at this time.
How is the new Cologuard test in 2024 different from the original? And how is it better?
That was, like the same thing that came up initially. They have expanded the number of genetic molecules that they're picking up. And so they may give you a more specific, and they've cut down on the false positives from the hemoglobin that would be in that test. So they have come up with a better sensitivity.
Okay, so someone was asking how many false negatives are there with Cologuard?
The Cologuard Plus is going to have a 94% sensitivity for colorectal cancers, and it's going to have a 46% for advanced adenomas.
Okay,
That
here's
will
someone
be
who,
2025.
here's someone who has a family member that was diagnosed at age 32 with no family history. Are you seeing more patients at this age, this younger age?
So I put this up in the slide. We are seeing people that are younger than 45. And, we know that a lot of celebrities got diagnosed with colon cancer at age 35 and 40. So we are seeing some of that coming up, and we don't have the exact reason as to why this is happening. It's probably a complex issue, as it was in the slide. It might also be that although we do not have the specific family history, remember some of the second, third, second degree relatives, you might not have a complete history. So that might still be playing a role for the Lynch syndrome or one of the other attenuated polyposis syndromes, which means it's not a full-blown form of FAP, but there may be attenuated genes. But it might boil down to multiple reasons why these patients are presenting at an earlier age. I've seen a 20-year-old with colon cancer, a rectal cancer, actually.
If someone does have colon cancer, this is part of the same question, stage 2, how frequently do they need to follow up with scans or other treatment?
So I would have, follow up with their surgeon and their oncologist. But the colonoscopy, we usually do it at least 6 months and then a year out. If the next 2 colonoscopies are normal, then you can stretch that interval out to every 3 years. And then, maybe 5. But initially, you keep a close eye on everything. So they get their blood tests looking for the CA level, and they get their CAT scans based upon what they're, even if it's a stage 2, but, how they were treated. So the oncologist and the surgeon that did the surgery would be the best person to follow up with.
Okay, when will Cologuard Plus be available?
Supposed to be sometime in May of this year. That was what was put out in their, publicity PR stuff.
Okay, and then I believe the last question is about the Sutab pills for colonoscopy. Have you had any luck with those? I guess this person stomach didn't agree. They threw up. They vomited.
So interesting, and they are very right in what they experienced. People prefer to swallow pills as opposed to drink gallons of liquid. And the liquid that doesn't taste good is actually, causes nausea. So I usually tell them, make sure that it's chilled, put it in the refrigerator, and then drink it when it's chilled and you don't taste it. The pills seem to be a good alternative, but there's a heck of a lot of pills, and you still have to drink the water. And the study that came out 3 years ago was presented at the annual meeting for the American College, showed that patients actually had gastritis with those pills. So that might have been what, the person that asked the question experienced. So although people do ask for the pills, and if the insurance covers it, because that's another kind of a negative for it, most insurances will not cover it. I'm happy with the patient that takes the preps. It's again like the test for the colon cancer screening. The best prep is a prep that gets done.
I'm sorry, there was one more question that came in. Do hemorrhoids present a challenge during colonoscopy?
No, they don't. And people do have hemorrhoids. Sometimes they're very large. They are something that we like to document. And if they're causing a problem, then we have the colorectal surgeons either tie them up or remove them. So it does not present a problem to colonoscopy.
Great. That's all of our questions this evening. Thank you so much, Dr. Chokhavatia, for your informative presentation this evening. At
Liz,
this time, I'd like...
yeah, there's